So if you start evolving your practice and dabbling in dry eye, what you'll notice is, as I alluded to before, is the dry eye patients themselves will become more complicated, so get ready for that. But I think in the fact that we are evolving as practitioners, we're seeing more and more pathology. You know, when I graduated, it was pretty much like normal eye, give glasses and contact lenses, abnormal eye, referred. And that was optometry. You know, it was a 3-year course and there was a 4-year course, and literally it was a tick and a flick. I look at it now, it's anywhere from like 3.5 to a 7-year degree, and we're encouraged to manage pathology, monitor pathology, co-manage pathology, and I think you'll find that as you do more of this, so often dry eye is a part of it, right? And we've got a great position where we've got the time to not just co-manage their glaucoma, but also treat their dry eye. Or not just write to their GP about their diabetic retinopathy, but manage their dry eye. And I think you'll find as you position yourself, you'll find you'll see more pathology, and invariably there's more concurrent dry eye to manage. So it's a growth part of the practice. Well, Anna alluded to contact lenses, you know, and I've been very fortunate to do a lot of work with some great contact lens companies, and like there's been such an evolution of materials. Like the companies themselves are making the materials better and better, smoother, more lubricious, right? We've gone from monthlies that get dirty and, you know, to dailies, you know, but there's still a limit. If there's an inflamed eyelid or there's, you know, poor margin coming out, contacts still don't perform very well. I'm sure that most presbyopes that don't succeed in monofocal contact lenses is not because the lens optics is not where it should be, because they've got concurrent dry eye or poor blink patterns. I'm sure that's often a limiting factor. So if you want a really successful contact lens practice, you can't overlook dry eye as well. And for me, you know, the shining light was the fact that I met a refractive surgeon in 2001 who obviously would much rather get the scalpel out and do surgery than manage dry eye, but he realised to get the best outcomes, he had to manage dry eye. It was like a necessary evil. So I thought, you know, I can work hand in glove with this surgeon to help manage. And I think, you know, I was talking to Rolando before, I actually think in 5 years' time, there'll be more and more optometrists working in ophthalmology practices where all you will do is their dry eye. Right? You'll literally work, and rather than sort of work for them, you know, vision pressures dilate, you see the doctor, you'll be working in their clinics, autonomously managing ocular surface. And that's all that you will do, but there's a huge role for that. You know, I think that's something we haven't, you know, you see people dabbling in it, but I think in time there'll be more and more optometrists being fully engaged by ophthalmology to manage dry eye because of all of those comorbidities and how commonly we see it with other pathologies. You know, and we have to get this right. You know, we started with intraocular lenses and we were out of the gate keen. And I can tell you, we got absolutely burnt. It was just like, oh, here's a new IOL, let's just try it. And we did the same pre-op protocols, the same post-op protocols. And like so many doctors that dabble in multifocal IOLs, we got burnt. People were unhappy, the vision was smudgy, they couldn't read in low light. You know, some of them who are like 55 had spent 13 grand out of their own pocket because there was no cataract there and they still couldn't see properly. And then I did this massive 3-month journey after the surgery to make their tear film better, right? And they're unhappy and you're doing mates rates and trying to nurture them along. We thought, this is not going to work. We're not going to keep doing this process. So we changed the front end rather than the back end. And now all of a sudden we're getting amazing results. We're nailing it at plano or plus or minus 0.25. And it's so successful. And to give you an idea, when people come in and pay 13 grand to be glasses free, plus 0.75 post-op is not good enough. You know, a -1 still at 90 is not good enough. I will tell you, if you want to get great results with multifocal IOLs, you need to be aiming for that planar. You know, 45% of our IOLs are torics at 0.75. Right? And we'll sit there at the 2-week post-op and go, oh, it's sitting at 40, we wanted 37, and the doctor will rotate it to 37. Right? That's the level that we're going to get outcomes, and the tear film can impact that. You guys would know, you have a poor tear film, we can change your refraction all over the shop. You know, and bosses hate when you have multiple remakes, and it's like, it's not me, I can refract, but the tear film's rubbish, right? But you've got to get the tear film, right? You can't say you're not good at refraction, you'll lose your job. So, you know, tear film's so important, you know, and so for me, that was all part of why I wanted the best device I could get to help these people out. So MGD's obviously a big player in dry eye, you can't look past that. And we've discussed at length this inflammatory process, right? How I've got to get on top of the root cause of dry eye. So to me, you know, this is an important slide because it shows that there is such a competitive market now, which to me is pretty cool. When I started thinking about dry eye, there really was only eye drops. that was all we sort of had, you know, and there's been this explosion in technology now, you know, right through, you know, from all different facets. You know, you've had the IPL, you've had different ways to heat the eyelids, you've got Rexon eye using small pulse of electricity, multiple masks and devices and all sorts of things available. But they're all come at a cost, and that's why I think when you position IPL in your practice, it's not just always going to be on top of everything else. In many cases, the IPL replaces their other treatments. So they can reduce the number of eye drops, stop doing their hot compresses, you know, minimise or eliminate their eyelid hygiene. And you use Optilight and improve that fundamental process, the expenditure just shifts. It's not like this is on top of all their other expense, which is a really important point to make when you're offering this in your practices. So Optilight, it's in the corner over there, and I'm really excited. After myself, we'll be doing a demonstration with Rolando. As I said, it's my third device, and I want to go through now. There's a couple of, I suppose, key features that made me decide to invest beyond the M22 into the Optilight. And so, you know, there's a number of things that are unique, and you know, they're all going back to this idea of working on the whole eye holistically, upper and lower eyelid, and get to that root cause of dry eye. And looking at as many triggers as we can to treat with one device rather than multiple strategies from the patient themselves. So we've touched on how it restores the gland's health. We've touched on how it makes glands more expressible. Right, so here are your key differences. Right, and I'll go through these all in detail, but there's a number of differences in the Optilight machine compared to the M22, and even the M22 was very different to competitors. To give you an idea of how much, I suppose, technology and research goes into this device, I was approached once by a different company to launch an IPL device. They said, oh, can you help us launch this device? I said, oh yeah, let's have a look at it. And you turn it on, and the first screen that comes up is choose your energy level. And that's it. I said to them, optometrists are going to go, what the, like, there's nothing else to guide us. There's no, like, choose skin type or, you know, it was literally just you turn it on and it says choose your energy. I said, as an interface point of view, like, if you're an expert at IPL, you'll probably be happy to see that. But for most people, that would be an epic fail. We like interfaces, we like some guidance, you know. Another company brought a machine out where you'd get the handpress and put it on the back of their skin and it would tell you what skin type it was. You know, and for a lot of that was like a massive selling point. They're like, oh, I don't really know skin. I'm too nervous to pick the skin from the machine or do it for me, right? But then that device had no gel and such low energy that it wasn't really therapeutic. I've had previous devices, and this is where I know things are different. One learning experience that I had was that I was treating a patient with M22, 13 gels, super happy, no skin concerns, and then I had a holiday, God forbid, and they went to one of our other clinics where they had a different machine. And they looked at my notes and gone, oh yeah, Holland's done 13 gels, patient's happy, we'll just do 13 gels. And they got out their machine and went 13 gels, and the patient got burnt, both cheeks. Now, it's like bad sunburn, it recovered, you know, but it said to me, wow, you know, these really aren't the same. And even within our same group of practices, we had a different machine. They looked at all of my notes, matched their energy for energy, and that person got burnt, right? So they aren't all the same, and it's the technology behind this machine that makes it different. So we've got a new little tip, and as Rolando said, the tip is fantastic. Like, ergonomically, it is so beautiful. But also putting that energy over a smaller surface area really improves that patient's comfort. So yes, you might do more flashes across the eyelid, but each flash feels nice rather than like just bearable, right? So it's a massive change. The interface is amazing. Like, I'll show you guys the interface. It is so much more user-friendly. You know, it's like Apple versus Android. No, just kidding. You know, it really is a fantastic interface, right? And they've thought about it. Like, as optometrists who maybe, you know, use this to get into dry eye, we don't want a scary screen that starts talking about pulse distance, and we just go, oh, I can pick the skin type, let's go, you know, and so it's done that. And really the OPT technology is, I think, a real point of difference in that the energy is consistent, right? I'll tell another story, right, of a machine that first came to market, and I went and saw it at a conference, and let's say that machine at that point cost $2,000, and it was very new, and I had a little card I put in it, and I was told that card gets you 1,000 shots. I've gone, cool, 1,000 shots per card, it's doing about 5 shots each eye, did it my sons, well, that's not too bad. But I thought, didn't have TGA approval, I thought I'm going to hold off for a year, right? So I go back a year later, It's not $2,000 anymore, it's now $4,000. I'm going, oh, that's okay, it's got TGA approval, there's a cost to the business. And I was like, cool, I think I might buy it, and it was still 1,000 shots per a card. And then I finally decided to make the investment, and then all of a sudden it's 500 shots to a card. And I'm like, why would it suddenly go from 1,000 shots to 500 shots? And it's because of that consistency of light, right? What was discovered, the more it was used in an eye world rather than a facial skin world, was that the energy wasn't consistent. So you don't want to sell someone a 1,000 shot card if it helps patients for the first 500 shots and the second 500 is not effective or sub-therapeutic. So to me that was a massive learning curve. I'd already spent the money, but I've gone from budgeting for say $1,000 to get 1,000 shots or treatments to all of a sudden it was only 500. So with OPT, they have eliminated that concern for us. Like this machine, it calibrates and delivers the same energy every time. You're not going to overcook it, you're not going to undercook it, you know, and it's a stable, consistent energy, which to me as a practitioner is really good for peace of mind, that I know that it's going to be exactly the same every time. You know, really, really important. So the little tip is fantastic, and I said it's so good to get those men with the big shaggy eyebrows and the deep set eyes, and before I couldn't get it in there. I was like trying to push their orbit out of the way, and it's like, it was just, they were not able to be treated. You know, even if I wanted to, I couldn't. The little tip is so cool. You get in there, you can zoom along the top lid, you can do the bottom lid up and over their nose, you know, you can miss that hairy mole that's in the way, or if you're feeling me, you can hit the hairy mole. But, you know, it's fantastic how small the tip is. I want you to have a look at the machine. It's made a huge difference to who I can treat. And, you know, the delicate contours now, rather than being a hassle for IPL, I can get in there and treat them effectively. The tip is also disposable, you know, in this world we live in, and for the FDA to give approval, they love the fact that it wasn't that same tip going from patient to patient to patient, right? So every patient gets a fresh sterile tip, okay? It also regulates the energy and even provides that perfect spacing. I know Orlando and I often would do like demos, and I get people to put the IPL tip on my face, and someone would push so hard, I'm like, how can that vessel absorb any energy? You're squashing it, you know, take it easy. Now use my fairy touch. I said fairy touch is good. With this great, with the OptiLight tip, an OptiTip, it's designed that you can just gently rest it down. There's a bit of a spacing on the plastic tip, so you get that perfect alignment every time, which is fantastic. So here's the interface. Look at that, that's so much more Apple, right? It's nice, it's coloured. I can see I'm treating the face, I'm not treating the leg. Good, excellent. It shows really clearly at the top all the skin types. If you change from the OPT handpiece to the larger handpiece, the graphics instantly change, so you're never going to get confused in terms of your energy levels. It's such a simple, easy platform. So for me, from a user point of view, particularly if you're not comfortable and you're sort of using IPL, it's so much more intuitive. You can still adjust your energy levels. So let's say you're sure it's Fitzpatrick skin type 3, and you do a little test pulse near the end, they go, woo, Nelly, easy. You go, that's okay. You just go down a joule. Right, so even though there's all of these presets based on FDA approval and the TGA approval, everything's pre-programmed, preset, you've still got that little bit of user interface where you can actually adjust it down a little bit if you want to. So this is a fantastic part of this new device over the M22 and even other devices on the market. Interface-wise, all that sort of, you know, fearful of like, what am I going to do? Might I get it wrong? It's really, really clear, which is fantastic. The other thing is, you know, we discussed before the treatment protocols and how often you do it. You know, you've actually got two handpieces on OptiLight. So you've got this little OPT handpiece, which is that intricate upper lid and the lower lid, but you've also got your more traditional larger head 35mm handpiece as well. And I would encourage you to not just do just the, even though you've got this great little tip, I still use the larger one to do the cheeks. As Orlando has shown, that basket just starts in the cheek and it spreads up over, right? I use the smaller tip and then I use the larger one as well. Because as I said, why not treat this holistically? We know it's not just the glands are fed from vasculature over the whole cheek area. And if they've got rosacea, you get that added benefit of improving their skin as well. But you've got the two different tips in the same machine, which I think is fantastic. So we sort of discussed, you know, this landscape, you know, and why this is so important to sort of, you know, think about this as being that next level of practice. You know, it's a point of differentiation. A lot of your colleagues are going to be out there doing their hot compresses and recommending lid hygiene. This is a real point of difference. And I think a lot of us are moving towards a medical model. And I think potentially even with COVID and, you know, other challenges in the market, more than ever, I think people who are keen to sort of I suppose, distance themselves from that more retail side of optometry, this will go hand in glove with you becoming the glaucoma expert, the diabetic management, you know, the co-management with your ophthalmologist on your macula as well. Like, it's a really nice little segue to work together. And, you know, from my point of view, it'll change your referral base ultimately as you get more positioned as being a dry eye expert. So, additional benefits. As Orlando said, side effect was great skin. I've got a really interesting story, right? So I had this lady, she was a semi-retired neurologist, so she was quite fascinated by what I was doing. And she came in and she had this crazy asymmetry in her dry eye. So breakup time on the left was like 18 seconds and it was like 3 on the right. And I've gone, look, you know what? I'm going to do IPL on just one side. I said, because really it's hard to justify it medically on the other side because your oils are clear. Everything looks great. So we started treating her and I think I got to like number 7 and she's come in, you know, this is a really smart lady, and she's gone, oh, Jason, I've got a problem. I'm going, oh, shit, what have I done? She goes, look at me. And I had a look. And on the eye I'd been doing IPL on, her skin was just like, oh. On the other side, it was a little bit wrinkly. And she goes, I don't like it, look at this. Can you treat the other side? I'm going, oh, phew, yeah, no worries. I can treat the other side. But like, it was like someone like that, I literally had only an IPL on one side. You know, that side effect was really quite obvious for her. You know, and she's going to have, I think, 20 treatments on both sides, and it's all evened up. But you can really see it, you know, and often it takes you time to realise that. If you were doing, I suppose, always both eyes, you'd never see it. But for her, it was amazing the difference after just 7 IPLs. You know, that one eye was just, the cheek was smooth, because I was doing her whole cheek, and the other side I did nothing on, was notably, in a mirror, you could see the difference. Right, so it is a nice side effect of IPL to treat dry eye, that you do improve the appearance of their skin just below the eye, which is fantastic. So I think it's really exciting what we've got available to us. I think, you know, from a point of view of where Lunas has gone, you know, they've taken a very good machine with the M22, which, you know, treats dry eye beautifully, but all the, I suppose, nuances that people like Orlando and I would give them feedback to, rather than just go, yeah, whatever, Orlando, back to your box, you know, yeah, Holland, we're sick of hearing from you. They've gone, let's take it on board. Let's think about the fact that we're now using this for eyes. We want to do upper lid. We want it to be more comfortable. Okay, and Opulite's really taken that technology to that next level. So we'll do a demonstration now, and I think, you know, it's really important that you see all of these new elements to it. As I said, and from my point of view, I haven't done it myself. Everything new I try myself, and I can guarantee you, in terms of the feeling, the OPT tip makes this so much more comfortable than the traditional treatments with the larger tips. So yeah, it's all pretty exciting. So thank you, and we'll head over to the live demonstration.